Hello, good afternoon, everybody. And I am Dr. Praveen Chandra from Medanta Medicity Hospital in India. And this is my colleague, Dr. Abhinav, who is going to be with me in this case. 79-year-old patient.
79-year-old gentleman. So, patient is a known case of diabetes, hypertension, and had underlying CKD with EGFR of around 35 to 40. So, patient today's creatinine is 1.4, and history going date back to 3 months. Like 3 months back, patient had ACS. At that time, he was managed conservatively. Now, the angiography has been done yesterday. So patient is showing blockages in two artery with LED having around 90% stenosis and RC also having 90% stenosis. Keeping creatinine and raise low GFR in account. So sir has decided to do it in ultra low contrast PCI. So sir has advanced the wire without contrast, keeping the previous angio in the other view. And now we have dilated the lesion.
RO caudal, please. Yeah.
So now sir has put IVUS catheter in the LAD, and we are taking IVUS of LAD. After pre-dilatation with 2O balloon, 2O balloon. So the IVUS image has shown around 80% plaque burden in the LAD proximal part. Now the further plan will be discussed by sir.
Okay. So can we see the angio? Okay. So this, patient is 79-year-old. He has renal dysfunction and has a very high chance of contrast-induced nephropathy. His angiogram was done with, maybe about 25-30 ml of contrast. And as you can see here, circ is okay. There is a OM disease at the ostium, not very big, but the LAD is tight stenosis, as you can see in this angiogram. And is in the proximal part, there is a long lesion about, maybe needing a 22-23 millimeter long, and then we will select which size of stent we take. Yeah, so the RCA also has a disease. So this is the right artery, which is also tight stenosis. So the plan is to do a plasty to both RCA and LAD. Everything is simple, but the complexity here is that this is a renal dysfunction patient and his GFR is around 30-35, and we will have to finish this whole procedure in minimum contrast. Although his upper limit is 30 ml, but we will try to finish in about 5 to 7 ml. And this will be our ultra low contrast PCI procedure, and we will not put any contrast as much as possible. So what we have done here is go to the first shot, please. So we have engaged the left with a 6 French guiding catheter, and this wiring is done with the help of just images which were from the previous angiogram. No further contrast has been injected, and you can see that the wire is progressing quite well, slowly, and we are using the same images to guide us through the entire procedure. So this is the wire, which is a BMW in position. And now we are dilating with a 2 millimeter balloon and nothing, no contrast. Now this is the IVUS imaging. So please show the IVUS imaging. And here I have taken a fluoro shot of this IVUS catheter because this is the landing zone. So this will give us an idea where to land. And the landing zone, how much is the distal reference diameter? About 3. And proximally, again, it is about 3 to 3.25, which is okay. There is no heavy calcification. So this gives us the full, information about what kind of strategy we have to take, whether we need to take any decalcification device or any other adjunctive devices. Most likely not. And so everything seems to be okay. So the length of this stent has to be, show me the first angiographic images. So normally what we do is we keep looking at the angiographic images on a different system, or we can take a printout and put it somewhere there. So based on this angiogram, it appears that we will be needing nearly a 30 to 33 millimeter stent say that it will be about 33 or 36. So, but here, this patient is in our trial, which is the Tuxedo 2 trial. In Tuxedo 2, the patients are randomized into either Zines family of stents or the Supraflex Cruise. So on randomization, this patient goes into the Zines stents arm. So we will take a Zine stent, and here we will take a Zines maybe 3 into 38. Yeah, 338, please. And you can see that, after the pre-dilatation, the ECG is okay. The the hemodynamics, everything is okay, and there is no major branch coming out, so we are absolutely fine. So this is the only time when I typically use some contrast to check the location of my stent's positioning. Go to epicranial. Don't inject.
No.
Epicranial looks like that we are in a good position, because now you can match it with the previous shot. Show me the previous shot, please. Yeah, so this is the proximal location of the stent, and back, and this is the distal location. Okay, so based on this, since this is 32 millimeters, and to me it looks all right. Now I will take a shot of 2 to 3 ml. This is diluted contrast. Okay, yeah, that's perfect, reasonably fine. We can go a little bit inside. Go up, please. 1, 2, 3, 4. Okay, and the distal vessel is like just 3, so I'm not going too high. And this is nominal is 8 or 9.
It's 9.
9. 10. Okay, go to 10. So we generally inflate for about 15-20 seconds, or even up to 30 seconds, because that gives a good expansion of the stents. Deflate, please. This is done. So now again, I'm not checking anything. Hemodynamics, ECG, everything is okay. I'll take the IVUS catheter now and give some nitro if possible, because the BP is okay. Give some nitro, please. So we are giving some nitro. So it's always better to, vasodilate as much as possible. And there was maybe 1 ml of contrast because of the previous. We drain it out and then inject the nitroglycerin. Okay, now you can see the IVUS. Okay, this is perfect. The distal edge is fine, and the stent seems to be expanded reasonably well, but here maybe we'll have to do some more. So this is, you can again shoot it so that we know exactly where it is. The stent looks expanded well, and here maybe we'll have to do with a 3.5, because the apposition is slightly incomplete. Okay, so give me a 3 millimeter balloon first, and the proximal edge we will do with a 3.5. So basically, we will also use a OCT to see the stent final position and everything if required. Otherwise not. 4.7 is the MSA, which is fine, but I want it above 5 for this proximal LAD. So I'm going to dilate it more. It is 4.7. If it is 5.5, it is the best. So on OCT, it should be 4.5. On IVUS, it should be more than 5.5. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. So we are fine. Everything seems to be okay. Hemodynamics. So when we are doing ULC PCI, we have to keep an eye on everything, because that gives us an indication that the flow and the side branches, everything is preserved. So now I'm taking a 3.5, and we'll go with this 3.5 to higher pressures, dilate the proximal edge. Okay, can you come to the RO caudal? Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay, so we have done with a 3.5 at the proximal edge, and position looks okay to me. Okay, so now should we do a contrast injection or do a OCT? We can even document this with a OCT. So we'll do the OCT, and that too we'll do with saline. So no contrast. OCT catheter, we will inject saline. Ready with the saline. Fill the catheter with saline. Take some more saline. No blood in this. So there shouldn't be any blood. Okay, pull back a little bit. Okay, go epicranial, epicranial. We can pull it a little bit back. Yes. Yeah, just a minute. Okay, we are ready. Just a minute. Okay, I'm ready. Okay, shoot. So as you saw, we didn't inject any dye. The catheter came out and the images we'll show you. Show the OCT images. Yeah, looks very good. So the stent is well expanded, fully opposed. And we'll look at the proximal distal edges. Here there is some narrowing I can see. Proximal edge seems okay. Little, a little unopposed position, so we can use the same 3.5.
3.5.
Yeah. Okay. So I'm going to take a 3.5 balloon. Show me the size there. About 3.5 to 3.75. That's the reason. But the distal part is absolutely well expanded and no dissection at the distal edge. Go up 2, 4, 6, 8, 10, 12, 14, 16. Okay. Deflate. So now you can see that on stent boost, which is the online stent boost. How much?
8.
No, go more. Wait a minute, just a minute. We are little deflate, please. The balloon has gone little inside. Yeah, we can even do a routine, but on this it is so well visible that we don't have to give more radiation. And we can now check it with the OCT and IVUS, whatever. We can do OCT again?
Yes.
Yeah, we'll do the proximal part only. The distal part is already checked. So up till now, we have not given any contrast except 2 ml diluted contrast. That's it. So we have to consider a few things when we are doing ULC PCI. One, which guiding catheter will be appropriate. Two, what is the location of the origin of the vessels, and then the calcific points, landmarks, all that has to be ascertained. This should be fine. So we'll fill the catheter back again with the, we will see if we got some good images. Yeah, we will see. Yeah, we can see very well the proximal edge. Looks good now. Everything is okay. The ECG, the hemodynamics. I mean, this is why in this it is very important to see the whole thing holistically. Final IVUS, fine, fine, fine. Now you can see how big the lumen is. Very well. Yeah. This is the proximal. Okay, perfect. So I think we are absolutely fine. We are done. So we won't even inject to see how it is. Okay. So the LAD is done.
Yeah.
And we didn't
Yeah.
give any contrast except 2 ml for positioning. Okay. So now we'll do the RCA. MSA is how much? 7.4. That's X2 is good. So we moved from 4.7 to 7.4 after post dilatation with a high pressure balloon. 3 and 3.5. Okay. So you can see that, imaging, and here, we have this is the sync vision from Volcano, very easy to use. In no time you can do the imaging process. So now again you can see that we are trying to engage the guiding catheter without any dye. Okay, I think we are engaged. Now show the angiogram, and there is no wedging, everything is okay. Show the angio images for a recap, so we remember exactly what are the landmarks. Okay, this is the angio. So here we see that it is just at that acute marginal first one. So beyond between the two acute marginals, the lesion exists, which we will see while we are doing the imaging. Ostium is okay. So we have crossed. So this is a 212, same balloon which we used for the left side. Predilate this lesion. So we will look at this calcium which was there, which is at the site of lesion. Very small calcium though, but certainly it gives us idea where exactly we have to start this dilatation. So this is very tight, not crossing. So we'll take another balloon because this balloon has been used and it was a non-compliant balloon. That is why it has lost its for the right artery also. So this study, Tuxedo 2, is a multi-vessel randomization between Zymes and supraflex screws for diabetic patients. So this goes in easily. We will go up with this 2 millimeter. Go up, please. So it is slipped a little bit distal. Well done. Okay, go up. 2, 4, 6, 8, 10, 12. So now the lesion is given way. Deflate, please. So at this stage, should we dilate it more or should we do IVUS?
We will do IVUS.
We'll do IVUS. So we'll do IVUS and see what size the vessel is, and then accordingly plan the stent size. This 6 French RCA guiding catheter. So now we see that this is the normal segment. I'll pull slowly back to know where exactly we have to land. Most likely we have to land somewhere here. This is the landing zone. You saw that calcium on the angio also. And we see it here also, eccentric calcification. Previous IVUS run. Okay, fine. So it looks like 23, I think. 323. Stand please, 323. Zines. Why we are doing so? Because each marker is 10 millimeters and the distal imaging part is 2.5 millimeters. Will be the time when we will give 1 ml of diluted contrast. Okay, looks like we are at the right position. And now at this stage, I will take a 1 ml diluted contrast, please. Distally, I think we are absolutely okay. And proximally also we are fine. So I think we'll go up. I will go up to 3, up to 8 only, and then we'll reassess. Okay. The stent seems to be expanded. Deflate, please. Show the stent boost, please. The stent seems to be fully expanded. Stent is fully expanded. And I will do an IVUS now. The hemodynamics is okay. The ECG is okay. Stent is absolutely perfect. Distal edge is fine. Here it needs some more expansion. You see, this is the place where it needs more expansion, where the tight lesion was. And then proximally it is okay. So the proximal and distal edges are absolutely fine. And the middle, I will go with high pressures. So I will do some stent boosting. Okay, go up. So I've gone up to 16 atmospheres. And how much was the MSA to start with? 4.1. We need to go more. Okay, I'm just trying to do the proximal edge where we have some possibility to go a little bit in higher. Okay, go up, deflate. We are just at the edge, right? Okay. Go up to 4, 6, 8, 10, 12, deflate. So I think, on this, we are done. So for the left side, certainly sometimes we get little, image issues, but on the right side, you will see that it is absolutely no problems. However, if we get difficulty on the left side, sometimes we use the guideliner to go selectively into the circumflex or the LAD, whichever arteries we are treating. But in the left, we found good images, so it was fine. So now we are ready to inject. Ready to inject? Okay, inject. So we can see the images are much cleaner, nicer on the OCT on the right side compared to the left side. So this is absolutely beautiful. There is no dissection at the edges. The stent is well expanded. The struts are clean. Lumen area is 5.76, 5.28, 5.13, 5.5. So on OCT, if we get something above 4.5 is absolutely fine. So we are done on this artery also. I don't think we need to inject anything further. We are done. Hemodynamics is okay. Everything is okay. Okay. So we are done, and keep an eye on the creatinine, but I'm sure with 2 ml contrast, his creatinine is not going to go anywhere. So thank you very much, and hope to see you next Wednesday. Bye-bye.